Guys, good evening. Right. Hi, good evening, good evening. Can you all hear me? Can you all see me? Check, check, check. I think the audio is there. It's clear. It's okay. All right. Hi, Mansoor. Good evening. Hi, Mr. Dawkins. Good evening. Yesterday we couldn't do the lecture because I had an emergency. So there was a case that we had to rush in. By the time we finished, it was around evening, night 1:30. So it became quite difficult. I couldn't, come and do a lecture. Some days we'll have these emergencies. We'll try to compensate. Hi, some user. Namaste. Good evening. So we'll try to make it up for whatever sessions that we are not able to do so. But then we'll keep this context alive. I didn't want to, go into a different zone of topic. So what we'll do today is, because we have completed the entire thyroid, I will do a parathyroid. That's an extension of the thyroid component only, and then we'll try to finish it up from thereafter, right? So today's topic that I would like to concentrate would be on parathyroid. So we're talking about the component of parathyroid. Okay, so hi sir, is there any class for first year MBBS, please? Guys, we do have the classes for first year MBBS as well. Any student who is into medicine, who is doing his MBBS or other streams, surgical lectures are going to be relevant. We'll be talking about all the basics of it. I'm not going to go into only into the surgical details, but the entire topic as such. Sorry. Okay. Okay, so without wasting any further time, let's kickstart the discussion for today. Chalo. So we're talking about parathyroid glands. I hope everybody is aware of the parathyroid glands. They are the paired glands which are present on the posterior surface of a thyroid gland, right? So when we talk about the parathyroid glands, a quick component about it. Now imagine that this is the thyroid gland. So I'm going to give you the anterior view as well as the posterior view. So this is the anterior view of the thyroid gland that you have. And when you look at the posterior view, this is how the posterior view of the thyroid gland would look like, right? So when you look at the anterior side of the thyroid gland, you will see there is a paired gland which is present. So that paired gland will be present on the posterior surface of the thyroid gland, and this paired gland is what we call it as the parathyroid gland. So this is the parathyroid gland that is present on the posterior surface of the thyroid gland, which is on this context, right? So this is the anterior view. This happens to be the anterior view. This happens to be the posterior view. So you see this paired gland that you have, these are your parathyroid gland. This is what we call it as the superior parathyroid gland. PTG will be your parathyroid gland. So this is your superior parathyroid gland. And this happens to be your inferior parathyroid gland. This happens to be the inferior parathyroid gland, right? So you have total 4 sets. So you have on the, let's say if this is the right side of the lobe, let's say this is the right lobe, this is the left lobe. Now this will become left, this will become right because it's the posterior surface. You see you have right superior, right inferior, left superior, left inferior, 4. Same way, left superior, I will say, if I just have to number it in the same context. So this will become your third gland, this is the fourth gland, this is the first gland, this is the second gland, right? So you have the superior parathyroid glands and the inferior parathyroid glands, right? Now, for a simple context, if I recreate this diagram, let's say this happens to be the representation of the thyroid gland that is present here. And let's say these are the paired parathyroid gland that you have. These are the paired parathyroid glands that you have. See, they are not very fixed in their own position, but for the sake of understanding, let's say if I just draw a line that crosses through the isthmus, the parathyroid gland that is present above this is what we call it as the superior parathyroid glands. This is what we call it as the superior parathyroid gland, and one that is present below the level of isthmus, this would be called as the inferior parathyroid gland. This would be called as the inferior parathyroid gland. So you have the superior parathyroid gland as well as the inferior parathyroid gland. Now, what is interesting is during the embryonic development, you will see the superior parathyroid gland is going to be arising from the fourth pharyngeal pouch. It arises from the fourth pharyngeal pouch. And what is interesting, the inferior arises from the third pharyngeal pouch. The inferior arises from the third pharyngeal pouch, right? So rather than normally when you think, no, the third pharyngeal pouch should give rise to the superior parathyroid, the fourth should give to inferior, but it crosses over during the embryonic development. Hence, inferior is formed by third, superior is formed by the fourth pharyngeal pouch. Another interesting thing is superior parathyroid glands, they are usually constant in position. They're usually constant in position. That means I can expect them to be present at one particular location where I would like to find in general. Inferior parathyroid glands, on the other hand, they are variable in position. They are variable in position. Now, because they're variable in position, how would I basically try to localize them? Now, the best way to localize the inferior parathyroid gland, it is to trace the recurrent laryngeal nerve. So, when you trace the recurrent laryngeal nerve, you will see the inferior parathyroid glands are usually in front of the recurrent laryngeal nerve, right? So they're found in front of recurrent laryngeal nerve, right? So trace it, and in front of the recurrent laryngeal nerve, you can probably find your inferior parathyroid glands, right? So the very famous line in Bailey that is written, it says that the best investigation, or let's say the best way to localize a parathyroid gland is to find a surgeon who is experienced in parathyroid gland surgeries, because that not only requires skills, but that also requires a lot of experience in order to localize your parathyroid gland, especially during their surgery, right? Especially during surgery, it becomes very difficult to localize it. So the best thing that you have to do is to localize the surgeon who is well versed with your parathyroid gland. Now, we talk about the properties of this parathyroid gland. When you look at the properties of this parathyroid gland, let's try to understand and analyze what are the important contexts. This is the thyroid gland again. This is the parathyroid gland, which will be here. Just to tell you that it is posterior in location, I'm giving you this little bit of graphical representation to understand that we're talking about the parathyroid glands, which are arising, or they usually present in the posterior surface of the thyroid gland. They usually present on the posterior surface of the thyroid gland. They usually present on the posterior surface of the thyroid gland, right? Now, when you talk about their important properties, right, the first thing that you know, that usually the weight of each parathyroid gland will be anywhere between 30 to 50 milligrams, right? Second thing, the size of each parathyroid gland will be between 3 to 5 millimeters. It is between 3 to 5 millimeters. When you look at the color of this parathyroid gland, they're usually golden to reddish brown. Either they're golden brown, or they're usually red brown, or we call it reddish brown. Right? Now, When you look in simple context, so these are the properties of the parathyroid gland that you need to be aware of. Now, what is the basic function of the parathyroid hormone, right? So they secrete the parathyroid hormone. Now, one thing that you remember is what are the total number of amino acids that are present in the parathyroid gland. Remember, there are 84 amino acids in parathyroid hormone, right? So if you look at this, how many parathyroid glands do you have? 1, 2, 3, 4. There are 4 parathyroid glands, right? So that is 4, and they look like a figure of 8, right? They look like a figure of 8. So hence 84 amino acids. That's one way to remember it, right? It's going to be one way to remember it. So just remember as 84 amino acids. That is the total number of amino acids that you will find in a parathyroid hormone. Okay. Now, in simple context, just to get the perspectives, imagine that this is the bone that is present. And let's say this is the cortex of the bone that you have. And let's say this is the blood vessel, right? So what is going to happen? There is one hormone that is going to take the calcium from the bone and gives it to the systemic circulation. And there is another hormone that takes the calcium back from the bone and it takes the calcium from the circulation and gives it back to the bone itself, right? So there are two hormones which are working against each other. One hormone is bringing the calcium from the bone into the circulation. Another hormone is taking the calcium from the circulation and giving back to the bone. What is this hormone, right? I'll say this is hormone number 1, this is hormone number 2. So which is 1, which is 2, right? Remember, 1 is your parathyroid hormone and 2 is your calcitonin. So you remember our thyroid lecture, I told you the parafollicular C cells that they produce calcitonin. Their function is to take the calcium from the blood and give it back to the bone, hence maintaining the concentration of the calcium in both bones as well as in the serum levels, right? So normal serum calcium. So when you look at the serum calcium levels, the normal serum calcium level will be 9 to 11 milligram percent, right? Less than 9 would be called as hypocalcemic status. More than 11 will be called as the hypercalcemic status. As simple as this, right? So this is the basic background about a parathyroid gland that is present. Now, another interesting thing about the parathyroid gland is its blood supply. So when you look at the blood supply of the parathyroid gland, the blood supply of the parathyroid gland usually comes from the inferior thyroid artery, right? You take this as a representation of the inferior thyroid artery, you see 80% of the times, guys, give me a second, just hold on for a second. Hello? Yeah, I'm in class. Yeah, class. Anything urgent? Nothing, no. Achha, okay, yeah. Bye. Right. So we're talking about the normal serum calcium level, that is 9 to 11 milligram percent. The blood supply was from the inferior thyroid artery. So 80% of the times you will get the blood supply to the parathyroid gland from the inferior thyroid artery, right? 20% of the times it can derive the blood supply from the superior thyroid artery as well as a combination of both, So this is your inferior thyroid artery. So this is a combination, that is your inferior. This is the inferior thyroid artery. Right. So blood supply to the parathyroid gland comes from the inferior thyroid artery. It supplies to both the parathyroid glands. 80% of it is supplied by, so when I say this is the parathyroid artery, remember 80% of the times, I'll just divide it this way, 80% of the times the parathyroid artery is derived from the inferior thyroid artery, and 20% of the times it can be derived from the superior thyroid artery. It can derive from the superior thyroid artery as well, right? So that is the basic that you need to know with respect to the parathyroid gland. Now, we will discuss about one of the most important disorders in the parathyroid gland, and that is going to be your hyperparathyroidism, right? So I'll take up the topic, which is quite niche and important also. So we'll talk about hyperparathyroidism. So when you look at this disorder, that is hyperparathyroidism, what are we trying to understand here, right? Now the basic objective of hyperparathyroidism, hyper basically means elevated or increased. It is either elevated or increased. It is elevated or increased. Parathyroidism is increased parathyroid hormone. It is an increased parathyroid hormone. So talking about an increased parathyroid hormone that is going to cause problems, that is called as hyperparathyroidism. Now the reason why they can increase, we can divide them into the following context. I can divide them into primary hyperparathyroidism, primary hyperparathyroidism. Then you have the secondary hyperparathyroidism, secondary hyperparathyroidism, and the third variant that you have is your tertiary hyperparathyroidism, tertiary hyperparathyroidism. So I can divide them into three different contexts. We can divide them into primary, secondary, as well as tertiary. So we have the primary hyperparathyroidism, the secondary hyperparathyroidism, and the tertiary hyperparathyroidism, right? Now, what is the basic difference between the primary, secondary, and tertiary? What is this, right? In simple words, how do we make a context out of it? In a primary hyperparathyroidism, the objective is quite simple. There will be increased parathyroid hormone. Hyperparathyroidism itself means increased parathyroid hormone. So I would say that there is presence of increased parathyroid hormone, but this is due to increased secretion. This is due to increased secretion. This is due to increased secretion from a neoplastic disorder. From a neoplastic disorder. Or we can simply say there's increase in parathyroid hormone secretion because the gland is producing more amount of hormone. It is not because of some feedback mechanism. It's as simple as that. In a secondary hyperparathyroidism, it is because of chronic hypocalcemia, right? So when you say secondary hyperparathyroidism, it is due to chronic hypocalcemia. It is because of chronic hypocalcemia. That is a secondary hyperparathyroidism. So when I say the tertiary hyperparathyroidism, when we talk about tertiary hyperparathyroidism, this is what we call it as the autonomous reactive hyperplasia. It is what we call it as the autonomous. This is referred to as autonomous reactive. It is an autonomous reactive hyperplasia. It is your autonomous reactive hyperplasia, right? So we have the primary, secondary, and tertiary. The primary hyperparathyroidism is due to increase in parathyroid hormone secretion from the gland itself. There is no mechanism or a negative feedback or a reverse feedback mechanism. Secondary hyperparathyroidism is because of hypocalcemia. Tertiary is because of autonomous reactive hyperplasia. Let's try to understand each one of them in their own capacity. So when you talk about the primary hyperparathyroidism, the best examples that I can give you, it is because of parathyroid adenoma, which is a benign lesion. Another one is parathyroid hyperplasia, again a benign lesion. And the last one that I can give an example here is going to be a parathyroid carcinoma. Right, so three disorders which can cause primary hyperparathyroidism, and that is your parathyroid adenoma, parathyroid hyperplasia, as well as parathyroid carcinoma. The carry home message that you need to understand: in primary hyperparathyroidism, the gland is producing more amount of hormone because there is new cells or new tissue that is formed, and that is secreting more amount of hormone. Hence, it is going to be your parathyroid carcinoma. Hi Adya, good evening. I hope you're good. Thank you, Mohammed Kamil. Okay, so Adya, you need to concentrate well. Today we're talking about hyperparathyroidism, okay? So stay focused. Focus, guys, okay? Chalo. So in secondary hyperparathyroidism, it is quite interesting. A patient is having a chronic hypocalcemia, right? So let's understand in a nutshell that how it is going to cause hyperparathyroidism, right? So let's dig into our world of understanding that how a patient will cause secondary how it is going to cause secondary hyperparathyroidism, right? So here the patient is suffering from chronic hypocalcemia, right? So there is decrease in serum calcium levels, right? Now this decreased serum calcium can be because of renal failure, it can be because of malabsorption, it can be because of vitamin D deficiency. Any reason, if the serum calcium is going to decrease, what is going to happen? Now we have already discussed that the mechanism that we have works basically between the bone and the systemic circulation. This is the bone and this happens to be systemic circulation. We have two hormones which are working relentlessly to maintain this balance. One of the hormone is bringing the calcium from the bone, giving back to the circulation. Another one is taking from the circulation, giving back to the bone. And this equilibrium of the calcium is maintained because of these two hormones, right? I hope everybody remembers the one that is bringing is your parathyroid hormone and one that is taking back is your calcitonin. Now, today we have a problem that the concentration of the calcium in the blood is decreased, right? Now, as the serum calcium level drops, body wants more calcium. So how will you get more calcium? The calcium donor in the body is your bones. Bone says, I am rich with calcium. Take all the calcium you want. Use how much ever you want it. Take it, take it, take it. Don't do that. ठीक है, ज्यादा अमीर हो और दिखाओगे तो बाकी लोग चूस लेंगे तो बाद में गरीब बन जाओगे. यही होता है बोन के साथ भी. ठीक है, तो बोन बोलता है ले लो बेटा ले लो कैल्शियम, लेकिन कैल्शियम लोगे कैसे? तो कैल्शियम लेने के लिए कौन आएगा? पैराथायराइड हार्मोन. सो द पैराथायराइड हार्मोन सेक्रीशन विल स्टार्ट टू इंक्रीज. As more and more amount of parathyroid hormone will secrete, it will cause more and more amount of calcium to come into the circulation, and this calcium will now become normal. ठीक है, now this compensation occurs because more amount of parathyroid hormone is driven and the calcium starts to improve in the circulation, becomes normal. But this increase in parathyroid hormone, it is because of this compensatory hypocalcemia, and this increase is what we call it as the secondary hyperparathyroidism. It is your secondary hyperparathyroidism, right? So in simple words, the secondary hyperparathyroidism is a response for your hypocalcemic balance. As simple as that. Okay? Now, where would you find these guys? I told you all the reasons that can cause hypocalcemia. For example, patient who is suffering with chronic renal failure. Patient suffering from chronic renal failure associated with malabsorption. And vitamin D deficiency. Right? So chronic renal failure, malabsorption, vitamin D deficiency are the common ones that are going to result in secondary hyperparathyroidism. So this is the basic difference between a primary and secondary. Primary में gland में खुद ही ज़्यादा हार्मोन बनना शुरू हो गया है because of these disorders, adenoma, hyperplasia, carcinoma. Secondary hyperparathyroidism is a compensation because of chronic hypocalcemia, more amount of calcium. So what is going to happen? The bone which was this thick, right? Just understand, as it continues to happen, the bone cortex, which is going to be this thicker, right? Because of this increased parathyroid hormone, you will see a lot of calcium will start to go away. So the bone will lose its density. So the bone mineral density will become less. The bone will become brittle. The bone will become weak. It can easily break. Okay. So this is how you will have pathological fractures in secondary hyperparathyroidism. Okay. So simple words to understand, primary hyperparathyroidism is increase in parathyroid hormone because of secretion. Secondary hyperparathyroidism is because of a compensation due to chronic hypocalcemia. And the third one, which is your tertiary hyperparathyroidism, which is your autonomous reactive hyperplasia. This autonomous reactive hyperplasia is usually seen post-renal transplant. It is seen post-renal transplant, right? So what is going to happen is, let's say a patient who have a chronic renal failure. Now, during the phase of chronic renal failure, the patient would have gone into secondary hyperparathyroidism, as we just discussed it. Now, during that phase where the patient is going to secondary hyperparathyroidism, how are you able to get more amount of parathyroid hormone? You are able to get more amount of parathyroid hormone because there's a compensatory hyperplasia in the parathyroid gland. And that hyperplasia will produce more amount of parathyroid hormone so that the calcium can get back into the blood and the equilibrium is maintained. Now, during that phase where the patient is suffering with chronic renal failure due to which he's developed hypocalcemia, the compensation is occurring because of hyperparathyroidism, and that compensation of hyperparathyroidism occurs because of reactive hyperplasia. Now, what is going to happen is, what is that reactive? It is a compensatory hyperplasia of the parathyroid gland. Now, this patient who had a chronic renal failure went into end-stage renal disease, the kidneys shut down, he was under dialysis, the patient was decided to take it for renal transplant. Now, once the patient undergoes renal transplant, the kidney starts to function. Now, once the kidney starts to function, what is going to happen? The kidney will start absorbing calcium. So, what is going to happen? Parathyroid hormone is still high, right? It will produce more amount of parathyroid hormone. More parathyroid hormone means more amount of calcium coming from bone into the blood. And the kidneys are also absorbing. What is going to happen? It will now create in hypercalcemia. So post-renal hypercalcemia or post-renal transplant hypercalcemia is because of this condition, which is called as tertiary hyperparathyroidism, because in those patients who underwent renal transplant, post-renal transplant, you see serum calcium is high, you do calcium levels, you do your parathyroid hormone, you see parathyroid hormone is elevated. You're thinking, oh, this guy has some issue with the parathyroid gland also. No. This is a compensatory mechanism. It will revert with time. You don't need to worry. So this is the difference between primary, secondary, and tertiary hyperparathyroidism. If you have understood this concept, I am telling you, you understood your parathyroid glands, right? If you have any questions, any doubts, I am looking at the chat box. It is your time to ask me a question. If you are clear between the difference of primary, सेकेंडरी एंड टेरिशरी, इसके बाद ना कभी ये डाउट मत रखना कि प्राइमरी क्या होता है, सेकेंडरी क्या होता है, टेरिशरी क्या होता है. सिंपल वर्जन, प्राइमरी में ग्लैंड खुद बना रहा है, सेकेंडरी क्योंकि डिमांड है, टेरिशरी डिमांड खत्म होगी लेकिन हम हैं तो बना रहे हैं तो बन ही रहा है पैराथायरॉयड हार्मोन, इसकी वजह से कैल्शियम बढ़ ही रहा है. तो प्राइमरी सेकेंडरी टेरिशरी में फर्क इतना, प्राइमरी खुद बना रहा है, सेकेंडरी क्योंकि डिमांड है, टेरिशरी क्या डिमांड पहले थी उसी गुमान में अभी भी पैराथायरॉयड हार्मोन बन ही रहा है, इसकी वजह से कैल्शियम का लेवल हाई होने लगा है. ठीक है, गुड नाइट आद्या, गो स्लीप, ओके, take care. I'll finish the lecture and get back to you. Chalo. Clear? Quick feedback. So I'm thinking, no doubts. Okay? I know, I'm too good, no? When I teach, when I explain, there's nothing left as a doubt per se. ठीक है? Alright. So, yeah, self boasting थोड़ा बहुत, अपने आप में वो मोटिवेशन लगता है. तुम लोग तो कर नहीं रहे हो मोटिवेट, अकेला बैठा मैं कैमरा से बात कर रहा हूँ. ठीक है? अब मोटिवेट नहीं करोगे तो सेल्फ मोटिवेशन इज ऑल्सो इंपॉर्टेंट. नो, तो आई वुड लाइक टू बिलीव इन द सेम. ठीक है, चलो. So we'll take up a topic which is going to be very, very important. We'll talk about something called as the primary hyperparathyroidism. ठीक है? सो बाकी जो सेकेंडरी टेरिशरी है वो मेडिसिन वालों का काम है, करते रहेंगे यार, मुझे थोड़ा कैल्शियम वगैरह ठीक करना, मुझे प्रॉब्लम है. देखो, सर्जन्स ओनली नो वन थिंग, इफ देयर इज सम इशू वी कैन गो रिपेयर इट, रिमूव इट और ऑप्टिमाइज इट. ठीक है, बाकी दवाइयों का काम हमारे मेडिसिन वाले करते रहेंगे. ठीक है, क्लियर है guys? If anybody has any personal queries or any patient related queries or any surgical queries, you can always reach down to me on my personal Instagram channel, that is the surgery guy. You will always find the link at the end of the lecture. During the lecture, I would not entertain any personal queries because it's purely educational. Yes, I'm more than happy to help you if it is required. Just drop me a message on my Instagram, I'll reach back to you. Okay, so don't worry about it. Chalo. So we'll be talking about primary hyperparathyroidism. So when I say we're talking about primary hyperparathyroidism, one second. Primary hyperparathyroidism. Now, we already understood that this is because of increase in parathyroid hormone secretion, right? Now, that increase in the parathyroid hormone, so it is due to increase in parathyroid hormone secretion. So what were the reasons for this increase in secretion? I can divide them into three categories per se. We have something called as the parathyroid adenoma. Then you have the parathyroid hyperplasia. We have parathyroid hyperplasia. And then you have the parathyroid carcinoma, which is extremely a rare cause for this, right? Now, you need to understand when we say parathyroid adenoma, it is the most common cause for the primary hyperparathyroidism. So this happens to be the most common cause of primary hyperparathyroidism. So whenever we use the word HPT, that means hyperparathyroidism, right? Now, on the other hand, when we say what is the incidence that you see across here, around 80 to 90% of the patients who suffer from primary hyperparathyroidism are because of parathyroid adenoma, as simple as that. Now, when you look at the parathyroid hyperplasia, this is going to account. So this is, I would say, the second most common cause. This would be called as the second most common cause of primary hyperparathyroidism. It is the second most common cause. It is the second most common cause for the primary hyperparathyroidism. Now, this is going to account anywhere between 15 to 18% of the entire component, right? Less than 1 to 2%. Parathyroid carcinoma is going to account for less than 2%, or let's say less than 1%, not even 2%, less than 1% of the total cause of the primary hyperparathyroidism, right? Okay, so Elevate, what is your question, sir? I am currently in second year MBBS, which will be over by January. So what should be my strategy if I start studying PG in third year, willing to learn from you from next year? Okay, now this, okay, fine. We have one interesting question that if you are currently in your second year and you're entering into your final year, because of all the NMC fiasco that has been going on, what should be your strategy? Because either you're going to have two subjects and then your fourth year is going to get burdened. My sincere advice to all the guys who are in their MBBS right now, once you get into your third year, ideally you should start surgery and medicine from third year itself, right? The reason being, surgery and medicine are going to be quite vast. You need to spend a lot of time. I'll give you an advantage because if you've done your first, second year, you have done your anat physio biochem, you have done your path pharma as well as your micro. So you have all the basic subjects required to ace these two giants, that is your medicine and surgery, right? So in medicine, you would require obviously a lot of physiology, biochemistry, pharmacology, you know, your pathology also goes into there. And micro. So you have all that together, and then the treatment protocol is nothing but usage of medicines, drugs, and all that. So pharma and all. So if you have a sound knowledge of all these, and then you start reading medicine, it makes sense. Same for surgery. Anatomy is most important. Physiology is important. You need to know a lot of pharma as well. Patho is going to be invariably inbuilt into the surgery. So if you're good with these, your surgery becomes easy. So as a third year student, you should start reading medicine surgery on a daily basis. Okay? Now, that is why, you know, this BLS series is also started where we are doing 1 hour per day and 3 days a week. That is more than enough for surgery from my end. If you follow this entire BLS series, 1 hour, 3 days a week, by the time we finish 1 year, you would have done entire Bailey. That means entire surgery would have been done. Now, what is it going to give you? It is going to give you that, you know, extra edge when you go into your final year, that you have already prepped well with your surgery, and when you start reading in your final year, it becomes revision. Now, once you have done that, you have done your first year, second year, you have done your third year subject. When you are in final year, the amount of time you have to spend on medicine surgery is going to decrease drastically, so you can concentrate on other subjects and you get a good grip out of it. So that's how you should plan it. It will be a game changer if you're going to start it early. Medicine is all about how many times you can read, how much you can understand, how much you can analyze. It's the notion that you need to put into yourself that it takes time to understand and then remember and then reproduce. Okay? So take that into consideration. I would strongly recommend all my third year bachas, if you're into your third year right now, start studying medicine surgery. They're absolutely important. They're big. They're huge. You will get stressed when you go into final year. So start in your third year itself. Okay? Chalo. So you have the parathyroid adenoma, the parathyroid hyperplasia, as well as the parathyroid carcinoma. Okay? Now, when you talk about these three causes, all these three will result in primary hyperparathyroidism. But how do I know that a patient is suffering from a primary hyperparathyroidism? So we'll be discussing about the clinical features of primary hyperparathyroidism. So patients who are suffering from a primary hyperparathyroidism, they will present to you with a classical set of symptoms, and that is what we call it as a classic pentad. They will present to us with a classic pentad. Now when I say pentad, it's a combination of 5 symptoms, right? So a classical pentad, so it will be 5 things that you are going to get into. That is your classic pentad. Now what will be covered in this pentad? You will see these patients will start developing, or else I'll make it easier for us to understand. In this classic pentad, the patient will develop kidney stones, along with kidney stones, there will be presence of painful bones. Kidney stones, there is painful bones. Then there is abdominal groans. There is this abdominal groans. Then you have psychic moans. Psychic moans and fatigue overtones. And fatigue overtones. So these are the symptoms which are considered to be as a classical pentad. You have the kidney stones, you have the painful bones, you have the abdominal groans, the psychic moans, as well as the fatigue overtones, right? Now let's understand why will there be kidney stones. Now the concept is quite simple and easy to understand. Now kidney stones in primary hyperparathyroidism, because there's excessive amount of calcium that is coming from the bone into circulation. Now that excessive amount of calcium that is coming into the blood will go into the kidneys for renal filtration. So obviously the concentration of calcium in the kidneys will also increase. Because of that, the patient will now present to you with development of renal stones. Now these renal stones will present to you with recurrent episodes. They will present to you with recurrent episodes of ureteric colic. They'll present to you with recurrent episodes of ureteric colic. Now, as the concentration of the calcium in the kidneys will start to increase, it will result in nephrocalcinosis. It is going to cause nephrocalcinosis, that is calcification of the renal parenchyma, and this nephrocalcinosis will cause decrease in renal function. Now we all know whenever the renal function starts to drop, you will see there will be decrease in GFR, that is a glomerular filtrate rate. Whenever the GFR is going to fall, we have a compensatory mechanism in the body, and that compensatory mechanism in the body is the activation of renin-angiotensin-aldosterone system. Now we all know whenever the RAS system is going to kick up, what is going to do? The RAS system is going to increase the concentration of aldosterone. Whenever the RAS system kicks in, it increases the concentration of aldosterone. So what does this aldosterone do? Now we all know, or else the simplest way to understand what is the basic function of the aldosterone, you have a mnemonic that you can remember that is A, B, C, D, E, right? Now A stands for absorption. Absorption of what? It is absorption of sodium as well as water. So whenever there is low sodium, again RAS system is going to kick in and try to help you. B stands for it is going to cause blood pressure maintenance. It causes blood pressure maintenance. C and D, that is the collecting duct on which the aldosterone is going to act. So collecting duct is the site of the nephron on which the aldosterone is going to act, and E stands for excretion of potassium. It is going to cause excretion of potassium. Now this blood pressure maintenance is basically because of it causes the vasoconstriction, and that basic vasoconstriction will now result in hypertension, and this hypertension is what we call it as renal hypertension. So when the RAS system is going to kick in, it is now going to present to you with renal hypertension. It is going to present to you with renal hypertension as well, right? So you have patient who is going to develop recurrent or repeated episodes of renal stones, which will present as repeated episodes of ureteric colic. We'll talk about in details in our urology lecture that how a patient with ureteric colic is going to present to us. It will cause nephrocalcinosis, it will cause damage in the kidney, and that damage will initially present to you as hypertension, and then obviously renal associated injuries are going to be present. So this is how a patient of the kidney stones is going to present to us, right? When it comes down to painful bones, right? So how does a patient of painful bones is going to present to us, right? Now in painful bones, as you know, there is increase in parathyroid hormone. This increase in parathyroid hormone will cause increase in serum calcium level. But you need to understand the calcium that it is increasing. How is the calcium being brought? Now calcium is increasing into the blood circulation. As the parathyroid hormone increases, it increases or it can cause increased osteoclastic activity. It is going to increase the osteoclastic activity. Now as the osteoclastic activity will increase, it will take more amount of calcium and gives it to the circulation. So the serum calcium will increase, no doubt about it, right? No doubt about it. But the concept here is, as the osteoclastic activity is increasing, as more and more amount of calcium is going to go from the bone, what is going to happen? The bone mineral density, which was called as the BMD, we call it as the bone mineral density. What is going to happen? The bone mineral density, it is going to decrease. Now, as there is decrease in bone mineral density, I would like to ask you a very basic question. What will happen to the weight bearing capacity of the bone? If the bone density is becoming thinner, so obviously the weight bearing capacity of the bone is going to decrease. So this will cause decrease in weight bearing capacity. It will decrease in weight bearing capacity. Now as it reduces or weight bearing capacity reduces, every time the patient stands or position himself a longer duration, obviously bone size, like I can't hold it. I don't have it in me. I'm weak now. I cannot take your weight. Sit down, lie down, sleep. And that is how your bones are going to scream. And that will present to you as painful bones. That are going to present to you as painful bones. So we doctors are going to use fancy terms to describe this entire phenomena. We say it is called as osteopenia. Osteo is been, penia is going to be loss or becoming less. Osteopenia, bone is becoming less, so hence it is going to result in problematic conditions. So osteopenia is telling you the bone mineral density is reducing. Now this reduced bone mineral density will result in brittle bone, that is called as osteoporosis. Osteoporosis is brittle, weakened bones, and these osteopenia and osteoporosis increases the risk for, as Mansoor is saying, pathological fractures. It increases the risk of pathological fractures. So these patients, without having any trauma, he'll say, suddenly I was sitting and I broke my hip bone. I was leaning against a wall, my hand broke. So all these are a classical examples of pathological fracture. How do you describe pathological fracture? A fracture of a significant weight-bearing bone without having any significant trauma. So injury or a fracture to bone with trivial trauma is what we call it as pathological fractures, and that is what you're going to see in these patients as well, right? Now this will also present to you with a condition which is called as osteitis fibrosa cystica, right? So osteopenia, osteoporosis, osteitis, fibrosa, cystica are the three fancy words that we will be using to tell you that it is because of painful bones, and that is under the influence of hyperparathyroid secretion. As simple as that. Now, why will a patient have abdominal groans? Now, this is something which is going to be interesting. We'll try to understand. Now, abdominal groans occur because of multiple reasons. Reason number one, increase in serum calcium level actually activates the G cells inside the stomach, right? I hope everybody knows G cells. No, G cells are your gastrin producing cells. So what is the effect of the G cells? They cause increase in secretion of gastrin. We all know the effect of gastrin on the parietal cell. When the gastrin produces more, it activates the parietal cells inside the stomach. Now, when the parietal cells are going to get activated, they will produce more amount of hydrochloric acid. Now, as the concentration of the hydrochloric acid is going to increase, this will now result in peptic ulcer disease. And needless to tell you that peptic ulcer disease patient will present to you with abdominal pains. So this is going to be a hypergastronemic peptic ulcer disease. That's a very, very important concept that has been asked in your central exams, in your NEET PG exams also, that can you tell me one cause of hypergastronemic peptic ulcer disease? Hypergastronemic peptic ulcer disease can also be seen in hyperparathyroidism because of excessive serum calcium level. You see, it promotes the activation of G cells, produce more amount of gastrin, and that gastrin is going to cause peptic ulcer disease. That is our reason number one. The reason number two, now you can see increased serum calcium everywhere in the body. It will cause increased incidence of gallstones. Obviously, the calcium in the bile will increase. That will result in gallstones, and that gallstones will result in acute cholecystitis. That will result in acute cholecystitis, and that acute cholecystitis will result in abdominal pain. The third one, again, increased serum calcium level. I'll write it here. The third reason is increased serum calcium will also result in development of pancreatic ductal stones. Now, these pancreatic ductal stones will result in recurrent episodes of pancreatitis. It will cause recurrent pancreatitis. In fact, it is one of the reasons for development of chronic pancreatitis, and recurrent pancreatitis, needless to tell you, will present you with significant amount of pain, hence justifying your abdominal groans as well. So kidney stones, painful bones, abdominal groans, all these three have their precise reasons, and we have tried to discuss them in detail. Psychic moans. Again, as most of the psychiatric disorders remain as puzzle, here also psychic moan remains as puzzle. We don't know why, but patients with hyperparathyroidism, that is specifically primary hyperparathyroidism, has both anxiety as well as depression. We don't know why, but that is one of the findings that you're going to see. Fatigue overtones, it is usually secondary to proximal muscle neuropathy, secondary to hypercalcemia. It is because of proximal muscle. It is because of the proximal muscle neuropathy. It is proximal muscle neuropathy, secondary to hypercalcemia. Secondary to hypercalcemia, and that is your fatigue overtones. So this, my friends, is how you will see a patient of primary hyperparathyroidism presenting to you with a classical pentad. Any patient who is going to have a classical pentad, I would like to evaluate. Okay? Features of hypercalcemia is there. So when you talk in terms of investigation, right? In the investigation, I would like to run by the lab component. So here I would look at the serum calcium levels as well as the parathyroid hormone level. So you will see serum calcium will be elevated as well as the parathyroid hormone will also be elevated. Now here's an interesting thing. How do you differentiate between a primary hyperparathyroidism and a secondary hyperparathyroidism? In a primary hyperparathyroidism, in differentiation with the secondary hyperparathyroidism, we'll be measuring the parathyroid hormone level, we'll be measuring the serum calcium level as well as the serum phosphate level. Now here's an interesting thing about the parathyroid hormone. it not only controls your calcium, but it also promotes the excretion of phosphate via kidneys, right? So your parathyroid hormone is not only going to, relate with your calcium, but it also causes the excretion of phosphate via kidneys, right? So parathyroid hormone is responsible for maintenance or bringing the calcium into the circulation and excreting the phosphate out of the kidneys from the body. Now, in a primary hyperparathyroidism, as I told you, there will be increase in parathyroid hormone secretion because the glands are producing more amount of hormone. Hence, the calcium in the circulation will increase, but it will cause decrease in serum phosphate. Why? Because parathyroid hormone promotes the phosphate excretion via kidneys. Now, as hormone increases, phosphate will decrease, as simple as that. In secondary hyperparathyroidism, I am saying there's a compensatory hypertrophy of the parathyroid gland. Hence, there is increase in parathyroid hormone level. But why is this compensation occurred? Because of chronic hypocalcemia. So here the calcium would be less, or due to compensation it can become normal. Initially, patient had hypocalcemia. Because of that, there will be increase in parathyroid hormone. That is as a compensation. Increase in parathyroid hormone can make it become normal, but never high. So this works like a loop. You see, decrease in serum calcium level, increased the parathyroid hormone level, increased parathyroid hormone level, brought the calcium back to normal, and this goes in cycles and cycles. What is going to happen to serum phosphate level? Now here's an interesting thing. If the kidneys are normal, that means if the hypocalcemia is because of malabsorption, kidneys work fine, phosphate will decrease. But if the kidneys are damaged, let's say the patient is having a chronic renal failure, in that phosphate cannot be excreted, it will pull up in the body, hence the phosphate will increase. So in a secondary hyperparathyroidism, you can also know whether it is a renal or a non-renal cause. In a renal cause, the phosphate will increase. In a non-renal cause, the phosphate will decrease. As simple as that, right? So this is how you differentiate between your primary as well as secondary hyperparathyroidism, right? Now, so in a primary hyperparathyroidism, you see elevated parathyroid hormone, elevated serum calcium, and decreased serum phosphate levels. As simple as that. Now, once you have evaluated, now you're thinking in terms of primary hyperparathyroidism. I know there are three causes of primary hyperparathyroidism. Is it an adenoma? Is it a hyperplasia? Is it a carcinoma? So how do you evaluate? So the investigation of choice. The investigation of choice is going to be your Cysta-Mebbi scan. It is going to be your Cysta-Mebbi scan. Now, in a Cysta-Mebbi scan, what do we do? In a Cysta-Mebbi scan, we are basically going to give a compound which is nothing but 2-methoxy. We give 2-methoxy, 2-methyl propyl isonitrile. Sorry, propyl isonitrile, right? So this 2-methoxy, 2-methyl propyl isonitrile, what it does is it goes and sits in the mitochondria of the parathyroid cell. So if this is the cell, and let's say this is the mitochondria that is present, when you give this compound, right, it goes and gets concentrated in the mitochondria of the cell, right? Now, if you see more concentration, that means there are more cells. If the cells are more, obviously, because they retain in the mitochondria, more uptake indicates more cell, and more cell indicates that it could be a adenoma, it could be a hyperplasia, it could be a carcinoma. So based upon that, you will be able to predict pattern in which the pattern in which it is going to get filled up. I'll be able to make my diagnosis. Okay. Hi, Liaquat. Good evening. Welcome. So this is on the Cysta-Mebbi scan. So this compound, it retains in the mitochondria of the cell. It retains in the mitochondria of the cell, right? and then it gets washed out also, but it is retained for approximately anywhere between 20 minutes to 2 hours. So you have to do it immediately. So once you give this isotope, and then you have to scan it as early as possible. Okay. Now, based upon the pattern in which they are going to get uptaken, I can predict the component here. So we have 3 disorders that we have been discussing here. So we can have a patient with parathyroid adenoma. We can have a patient with parathyroid carcinoma. So you have to see, as well as hyperplasia. So we'll do a cheat code because I don't want to draw again and again. So we'll use a cheat code. So we are discussing about 3 disorders. Cheat code में थोड़ा cheating भी हो गया. ठीक. So we are going to talk about 3 disorders. One second, guys. Okay. So we have 3 disorders that you have. One is going to be adenoma, one is going to be hyperplasia, and one more is going to be carcinoma. So based upon system A-B's pattern, how do we differentiate whether you're looking at adenoma, whether you're looking at hyperplasia, whether you're looking at carcinoma? The component is quite simple. Adenoma usually involves any one gland. Hyperplasia, on the other hand, will involve all 4 glands. So there's uniform enlargement of all 4 glands. It is what we call it as hyperplasia. On the other hand, if you have a tumorous growth, which is going to be causing a local infiltration, so it will have a very diffused pattern that you have. So when you give the system A-B scan, you will see if the concentration of the isotope is only in one particular gland, and that is more, that is a hyper concentration is noticed in any one particular gland, and the rest of the gland has a normal uptake. This is what we call it as parathyroid adenoma. This is what we call it as the parathyroid adenoma. In parathyroid hyperplasia, you will see all 4 glands are going to have a hyper uptake. If all 4 glands are going to have hyper uptake, this is what we call it as parathyroid hyperplasia. In a parathyroid carcinoma, you see the uptake in the gland which is involved is going to be quite diffuse. So there's not a localized uptake. It's a lot of diffuse uptake and very irregular pattern, and this is what we call it as the parathyroid carcinoma. So based upon the pattern of uptake, we can differentiate them into adenoma, hyperplasia, as well as carcinoma, right? Now, once you've made your diagnosis about adenoma, hyperplasia, and carcinoma, what are we going to do? If it is a parathyroid adenoma, then we are going to do a adenectomy. So I'm going to remove the parathyroid gland which is affected. This, if I remove it, this is what we call it as parathyroid adenectomy. For a parathyroid hyperplasia, we will do something called as 3.5 surgery. So in a 3.5 surgery, I will remove 3 parathyroid glands completely. The 4th one, I will remove only the half. The other half that is left behind. The other half that is left behind, it is going to be reimplanted. It is going to be reimplanted. So where would you reimplant it? The current preference for reimplantation, that means to you're going to remove that half and you're going to put it somewhere else. You need a vascular bed. So preferred one is same-sided ipsilateral sternocleidomastoid muscle. Whichever side you're leaving. If you're leaving on the left side, attached to the left sternocleidomastoid. Right side, the right sternocleidomastoid muscle. Whichever side you're leaving it, you have to reimplant it there. The other option that you have is going to be the brachioradialis. It is going to be the brachioradialis of non-dominant arm. The brachioradialis of non-dominant arm. It is going to be the brachioradialis of the non-dominant arm, right? And the last one that you have is about the parathyroid carcinoma. Again, we'll have a detailed discussion on that as well. But now you have to remember, when you talk about parathyroid carcinoma, it is, if it is an operable malignancy. For an operable malignancy, I will do an N block. We'll do a N block tumor excision. That means you have to make sure that you don't remove it like a piecemeal. You have to remove in toto. In order to achieve this, I have to do, let's say, lobectomy. That is lobe plus isthmus. Earlier it was called as hemithyroidectomy. So some textbooks will still mention as hemithyroidectomy. But we have recently learned that the term hemithyroidectomy is now replaced with lobectomy. And then we'll do a central neck dissection as well. We will perform a central neck dissection. These are the components that we are going to follow, right? So it is going to be en bloc tumor excision. We'll do a lobectomy with central neck dissection. This is how you will manage if you have a patient of parathyroid carcinoma. So you had the entire discussion on primary hyperparathyroidism, their presentation, their diagnosis, and their management as well. If you have any other questions related to parathyroid gland, feel free to leave a message. We'll get back to you if there are any doubts, any queries. I'm always there for you. Any questions, anything, as I told you, if you have any personal queries, any surgical queries, anything that you want to ask, you want to connect to me, you can connect at the Instagram. It is called as The Surgery Guy. Again, this is by my name only, and my name is Dr. Sandeep Seeram Reddy. So, any questions, any queries, anything that you want to ask, anything you want to connect, let it be personal, professional, any advice, reach down to us on this, and we'll try to help you off, right? With that, let's end the session for today. Thank you so much. The next week's BLS series is going to be a bang. I am going to start something which is going to be very interesting, very important, and I'm going to tell you that every single doctor lives for that particular day. So meet me for the next week in the BLS series. Thank you. Good night.